you doing, friend?
I am so good. So good to see you. Yeah.
I know. So it's crazy. So listen, I'm gonna apologize. I had to sneak into the room. So if you guys hear any noise, it's just the kids. Don't worry about it. This is like, mostly unscripted. So we got a couple topics that we want to cover, so we want to make sure we get it out. But thanks everybody. This is the introduction to a very special series called The Love Below. So for those of you who don't know, I'm Dr. Erin King-Mullins, also known as Dr. Tushy Touch Up, and I am floored and honored when I think back at the full circle moment that we're getting to right now with one of my besties from day one, Dr. Soyini Hawkins.
Yeah. Thank you for having me. This is going to be fun.
So, take a moment and just introduce yourself. Tell us who you are. Well, actually, let me just start off real quick that, like, again, one of my day one besties, remember, I was floating around small town, Lake Mary High School in Central Florida. They're like, oh, there's a new girl that's here. And I'm like, oh, great. And who knew that she was going to be one of the most fantabulous people that I would ever meet, be a lifelong friend. Her mom would be my mom,
Yeah.
her siblings would be my siblings. Her grandma would be like my grandma. And for us to have this full circle moment is kind of insane. So we went to undergrad together. We were roomies for medical school, parted ways very, very briefly for residency and training, and our worlds recollided here in Atlanta several years later. And so I'll let Dr. Hawkins introduce herself and tell a little bit about that collision that we had.
Yeah, absolutely. So thank you guys for having us. And thank you, Dr. Tushy Touch Up, AKA Dr. Erin King-Mullins, my very best friend, for having me and kind of creating this platform where we can talk about the things below, right? Below the belt topics that are of urgent importance to the women I treat, but the women and men you treat, and need to kind of be discussed more openly and
Mhm.
discussed more readily. So, thank you, thank you, thank you. I want to start there. But guys, she's being honest. When I arrived at Lake Mary High School, which is where we went to high school together, Erin was everything. She took me in. She showed me the ropes. She made sure there were no mean girls that were gonna mess with the new girl. I know she remembers the stories,
Oh, there were
right?
dynamics. There were
They were,
dynamics for
they were
sure.
dynamics, but she was that girl. She was that thing. She was the smartest person in every single room that we went into from day one. And it just blew my mind how our paths really did align, all the way down to my first days in the OR when I came to Northside Hospital. So she had already been there, was familiar, was a fellow, knew the environment very well. And she, again, did the exact same thing, when I moved to Atlanta and started my practice about 11 years ago, and wandering the halls of Northside Hospital trying to get myself acclimated as a new surgeon on the floor. I wanted to do great things. I'm a MIG surgeon. I take care of endometriosis patients, which we'll dig into in this conversation. And I was like, Dr. King, come help me. And it was beautiful. We were in the ORs. We took pictures outside the OR for our moms, right? Both of our moms are our moms. Erin's mom is on here now. And just, share that full circle moment. And it truly was a blessing. And I'm grateful.
Wow. Um, one of the things that I learned very early on, I think throughout life and kind of what propelled me to be the type of person and surgeon and physician that I am today is that, if I get ahead, but nobody else is ahead with me, like, what are we really doing, right? Like, for those who, are spiritual or believe in a higher power or Christian, God didn't stop at Adam. He made Eve. And that is just, I think metaphorically, one of the things that kind of drives me forward in life because we are not meant to go through it alone, right? We're just not. And that's kind of the whole premise as well of this series that we're introducing. So welcome to those who have just joined us, the very first in a series, a special series that I've entitled The Love Below. And the whole premise behind this is there's so much collaboration when it comes to um, pelvic health, pelvic floor health. And while a lot of times we default to women just because of the traumatic nature of the birthing experience and all of those things that impact those things. Pelvic floor health, me as a colorectal surgeon, there's a bunch of other structures in the pelvis, right?
Right.
So there's for you the uterus that can develop fibroids and endometriosis. There's, the bladder, so many other things. And so we find ourselves connected in so many different ways in treating these patients. And so one of the main reasons that I wanted the famed Dr. Hawkins, who is one of the masters of gynecologic surgery, especially when it comes to fibroids and endometriosis, in helping preserve fertility for women who want options other than a hysterectomy. Sometimes that takes special treatment. So, can you tell us a little bit about some of the conversations that you have when you step away from patient shows up and they tell you about pelvic pain? Excuse me, pelvic pain and bleeding. They've been diagnosed with fibroids. Someone thinks they may have endometriosis, and then you start veering over a little bit to the rear, okay, to the backside, things that I deal with. Tell us a little bit about some of the things that can be affected colorectal wise when we're dealing with fibroids and endometriosis, and what kind of endometriosis and what conversations you have with the patients about that.
Sure. So one of the big things that we do when we evaluate patients, right? We kind of, maybe at this level, we kind of know what they're coming in for. My staff does a thorough job assessing them even when they call in and they're like, oh, I have fibroids, I want to see Dr. Hawkins. Or I've been told I have endometriosis, so I have a pelvic pain, and something showed up, right? And when they get in the door, sometimes the questions are after they understand, after they've kind of explained their journey, the question of their bowel habits and really more digging into what their pain actually is associated with usually comes as a question. People don't always divulge that. They don't always say, you know what, actually, yeah, I have been noticing that I'm constipated. I wasn't constipated before, or I have a little bit of discomfort with my bowel movements. They're less frequent, and not just less frequent, but then when they do occur, especially at certain times of the month, is what we hear a lot in the GYN gynecological world. They're painful. Some of my patients will not think about the blood that they saw in their stool until I ask them about it. And they're like, oh, actually, yeah, one time I did see that. And then I'm like, okay, now what comes next after that is I need you to see my friend. We do definitely collide more in the world of endometriosis, but just last week I did a significant fibroid case of a patient that had had two previous myomectomies and a uterine fibroid embolization and had a huge, probably about 15 centimeter fibroid that was completely plastered to her rectum. And it was getting its blood supply now from the rectum because it had UFE and the uterine supply was cut off. Those fibroids still have to eat, honey. They still
Yeah.
are going to seek out something. And I mean, that again is when we
Empathy.
look for our colorectal
Yes.
friends. Yeah, right?
Yeah.
Like the kids say, like the children say.
Right.
So I pull them out. I pull it out of them because understanding from back to front, especially that back, is vitally important, especially when we're preparing someone for possibility of surgery.
Yeah, yeah. And thanks for getting to that point, and making sure we have those conversations, because a lot of the conversations that I have with patients when they come with me complaining of a certain issue, it could be rectal pain, it could be pelvic pain, and I start inquiring, hey, what's your gynecologic history? Or do you see a gynecologist? Are you up to date on your pap smears? Has anybody ever explored the topic of endometriosis with you? And so then when we talk about colonoscopies, they may say, oh, I don't really have a problem with my bowels. um, but then when you ask those deeper dives and
Mhm.
questions, they realize, like, yeah, well, you know, yeah, around my cycle time, this may happen. And I know it's very common to have, maybe a change in texture and frequency of the bowels associated with the hormonal changes with
Right.
either ovulation or menstruation. But sometimes those things, again, they've progressed over years, gotten worse, and they just say, oh, it's just part and parcel to the way my cycle is. And, it's something that we need to know. And so then we start talking about colonoscopies, and they're like, I don't need a colonoscopy. No, nobody in my family has colon cancer. So then that goes down that whole, rabbit hole of letting everybody know, first and foremost, because it is Colorectal Cancer Awareness Month for March.
Yes.
Um,
It's endometriosis
Colonoscopy.
is in this month
That
too.
is right. That is right. Woo, our worlds
Yes.
collide again. Um, But when we go down those rabbit holes, like the colonoscopy is not just a screening
Correct.
examination, it's a diagnostic tool.
Yeah.
So, we are best prepared when we know full circle what's going on internally. If someone may have to have a portion of their colon or rectum removed or something like that. And so that's why we have this conversation. So it's like perfect that, very beginning of Colorectal Cancer Awareness Month, we're talking about the other things that
Mhm.
impact colorectal health, other reasons to get tested, to get a colonoscopy. So I know all of y'all are being bombarded right now, this first part of the month, about the stats and track records for colon cancer and polyps. I'll be talking to a GI doctor a little bit later on in the month. We're going to let everybody else handle that for now. And we're going to start making sure you guys are taking care of yourselves completely, especially you women taking care of yourselves completely. Because when you think about that pelvis, I know you just told the story about that big fibroid you removed last week, that was growing into the colon. But sometimes, just it's a narrow space down there. Your
Mhm.
abdomen is very different than your pelvis because your pelvis is lined by bones on the side. And
Yeah.
so there's only so much space that's there. And so if something's taking up space, it can block off your bowels. It can impact your bowels. And just over time, people get subtle changes, and they just kind of just deal with it, which we need to make sure that people are empowered to not do so. um let's see, I wrote down a couple of other things. um if you were to, based upon the conversation we're having right now and everything that you've seen in the world of fibroids and endometriosis, if there was like one super highlight that you would want someone to take away from this conversation tonight, what would that be?
Um, well, so it's kind of obvious that you're talking to two specialists, right? In the world of gynecology and the world of GI health, you are talking to two surgical specialists. And we believe in specialists. Like if you go to your primary care doctor and you're saying, I'm having palpitation, chest pain, my blood pressure is uncontrolled, and they feel like they've done their best and all that they can do in that evaluation and therapy they're offering you, they might send you to a cardiologist. There is power in knowing your resources and the people that are going to be the best at what they do for certain situations. So, in the world of gynecology, there are doctors that are what we call generalists that kind of do everything, which is great. They do obstetrics, they do gynecology. They will, talk about hormones. They will do your pap smears and your breast exams. Many times, generalists send patients to me that have fibroids, concern for endometriosis, things that they may need specialized surgery for. And there's nothing wrong with that. They're not telling you you have cancer and that, the world is
Mhm.
coming to an end and you can't have a baby, or that you need a hysterectomy, which is a point that Dr. King-Mullins hit early in this discussion. So don't be afraid when your doctor might recommend that you go to a colorectal surgeon, not necessarily just a GI doctor. Yes, they do colonoscopies too, but they might say, you know what, actually, you might need a higher level of care, or you might need someone that's not always necessarily going to say you have to have surgery first. Not everybody that walks in our doors are surgical candidates or it's necessary, but
Right.
sometimes that higher level of care is good, and you don't want to miss the ability to do that and get the best for whatever your current situation is. So a lot of people just don't know they're specialists like us. So I just
Yeah.
want to not necessarily, it's not even really a shout out or a big up, but at the same time, we are very passionate about what we do, and
Yeah.
we do it very intentionally for our patients because we feel like you guys deserve that level of care. So when your PCP sends you our way, that's why.
Yeah. And to double down on that just a little bit, um, well, you're a little bit different in the sense of you truly sub specialize within your world of gynecology with the advanced endometriosis and fibroids care. Colorectal surgery, we do a lot of a little bit of a wider breadth sometimes, medical management and things like that. And so I tell people, you know, maybe only about 50 to 60% of patients who see me as a colorectal surgeon actually end up needing surgery, right? And so don't shut yourself off to your future or your care because you hear someone's referring you to a surgeon. The surgeon needs to tell you if you need surgery or not, like,
Correct.
period, first and foremost. Um, and obviously, unless there's other major reasons that the surgeon may feel something may harm you if you're not a good surgical candidate for certain things. Um, if we tell you you don't need surgery and you're like, oh, well, my doctor said, and it's just like, we literally make our own money. We take care of these children. We pay the bills by doing surgery. So if
Yeah.
we're telling you you don't need surgery, it's for a reason and it's usually for your own good. And I'm not trying to be facetious, but so number one, don't be scared. Like, like
Yes.
literally, you always have the opportunity to say no to any service that is provided you. You have the agency and all that stuff. Um, so just a quick pause. I know some other people may have joined now. So reintroducing this series, The Love Below. Dr. King-Mullins, also known as Dr. Tushy Touch Up, here with the fab and amazing Dr. Soyini Hawkins, the most amazing fibroid and endometriosis, minimally invasive specialist in this country. I'll just say that myself because I know her personally. I've operated with her and almost had her operate on me. That's a whole nother story. Um, but yeah, so the Love Below, again, the series is a discussion of the multidisciplinary approach, the collaborative effort that is required to manage certain colorectal or gynecologic conditions. So later on this month, we'll be talking to other subspecialists. And part of our success in helping you as patients succeed and get back to your quality of life is that collaborative effort. And so, one of the things that we'll talk about in the future is with the urogynecology, or pelvic organ prolapse, the rectoceles, the cystoceles, the did I say rectal prolapse? I think I said that. But if I only repair my end of things and I don't have collaboration with a urologist, a urogynecologist, or a gynecologist that can do either that hysterectomy or sacrocolpopexy or all those other pexies, then there's a 30+% chance that my operation is going to fail because we have not addressed that pelvic floor as a whole, right? And so when we talk about endometriosis in your world, Dr. Hawkins, tell us a little bit about, if, how does someone fail your surgery or your procedure if there's not collaboration with someone like me or another specialist?
Yeah, so the great thing about kind of getting to that again higher level of care is we're going to do almost like a 360 evaluation. We're getting MRIs. Our examinations are going to be very particular to try to seek is there nodularity, especially if you're giving me a story that gives me concern about your bowel. And not only just that, sometimes you give me no story, but I see something on imaging, or I know that your ovaries are kissing, we call kissing ovaries or endometriomas. Many times that also involves the rectal sigmoid, that last part of your bowel. And so when we know that that might be a possibility and that might be necessary for surgery, to ignore it is to almost guarantee that you will not get a thorough treatment and you may have an early recurrence of your disease process. Endometriosis might most definitely is not cancer, but it kind of behaves like it. It is invasive. It is inflammatory. It continues to kind of not be proliferative, but it definitely, when it's left behind, will continue to cause symptomatology. And the number one symptom of endometriosis is pelvic pain, menstrual pain, pain with intimacy, pain with bodily functions like using the bathroom, both for the bladder and for the bowel. So if I leave all that endometriosis on the bowel, and mind you, I'm aggressive in my endometriosis resections, meaning I cut out endometriosis. I don't burn it. I ain't taking pictures and saying, hey, you got it and good luck. It's
Right.
got to go,
Got
right?
to go. Got to go.
However, I know I have my limits and I know how to phone a friend. The rule of thumb that I have when it comes to surgery for me and for my patients, because I treat my patients like family, is if I can't fix it, I don't need to be messing with it. So I
Got
might
it.
take endometriosis from everywhere else. But if you have deep infiltrated endometriosis into your bowel, and I really want the best for you from a post-operative care standpoint, I would like to have the very best experts in the room to make decisions about, can this be shaved off? Do I need to do a resection? Or even in that shaving, though, I can shave off endometriosis. I also know if I put a hole in it, I got to call Dr. King-Mullins. And I'd rather just have her in the room from the jump. So she can do it. And
Yep.
so It is definitely a collaborative effort. And I mean, I think that goes for most parts of what many of us do surgically, and especially for my endometriosis patients, even if they don't go to that level of needing someone like a Dr. King-Mullins specialist. I think it's very important that they know most of the way that we treat and take care of these complex diseases is collaborative. It is.
Yeah, sorry about that. So, yeah, and one of the things, and it's, and I will, co-sign on the fact of how aggressive these things can be. And I think, oh Lord, I'm still traumatized by that very, very first endometriosis case we did together. But that was kind of one of those things where someone had, some pretty aggressive treatment, gynecologically, had a hysterectomy. And Lord knows nobody thought that endometriosis was there, and that's what it was, like
Yeah.
causing life-altering and debilitating things. And unfortunately, at that surgery, we did have to, because that we didn't think it was going to be what it was going to be. She ended up having to have a colostomy temporarily. That was eventually reversed,
Yeah.
but that is truly how aggressive, these things can be,
Yeah.
and so we have to have that collaborative effort. So that phone a friend is just not about, like, making sure someone else, gets to get in on the financial aspect of it. It really is to make sure that we provide the best and most adequate care for you to minimize complication, to minimize recurrence, because we will do our best to make sure that we handle, the reason you're here to see us. Um, and so, and I'm going to put a plug in here just briefly, for my newer service offerings, the Tushy Touch Up procedure. So I've been doing it for about a year now. And it's kind of one of those things that, over time, there's certain changes that happen to the body and certain life situations. And there's a lot of women who've been through a lot,
Yeah.
childbirth, fibroids and endometriosis care. They may be, embarking upon a new relationship and they feel uncomfortable with
Yeah.
intimacy because some of the more physical changes that happen down there. But those physical changes can lead to functional changes, right? It's not just about, hey, I got a hemorrhoid down there, I got a skin tag over there. There's a little bit of sagging skin that can play a role in hygiene, comfort, how you actually evacuate your bowels. And so I just tell people, like, it's okay. I sometimes will, after they've described what their symptoms are, pain, bleeding, burning, itching, incontinence, and they start explaining to me the reasons why they want it done. When they start getting into their why, when we talk about intimacy or hygiene, I will lovingly say, hey, I'm gonna cut you off right there. And not because I don't want to hear what you're saying, because that doesn't matter. What matters is you get the care that you
Yeah.
want. So don't feel like you have to go through this whole explanation as to why you want something. You have symptoms, you want a solution, full stop. And I'm not the gatekeeper for you being your best self. And so I think we need to make sure that when we're taking care of these patients full circle, it's not, there are some degrees of aesthetics and cosmetics that do impact function and comfort and also mental health. If someone feels extremely uncomfortable and they can't, if they want to start a family or start a new family, and they feel like they can't do so because they're having pelvic or vaginal pain due to endometriosis or skin tags or something that's getting in the way of hygiene or their comfort during their intimacy to be able to
Yeah.
maintain or start a family, those are more than enough reasons to move forward with those types of procedures. So,
Absolutely.
yeah.
Mhm. Yeah.
Um, yeah. So, let me see. What else did I write down that I wanted us to talk about?
I
Any
have a
questions
couple
in
of
the chat? I
questions.
don't know.
Yeah,
Yeah,
I
go
got a
ahead.
couple of
Go ahead.
questions for you. Okay, so one question that came up from my very, very good friend Laurencia, because she's awesome. She says, what are the poop signs you may need to get checked? Like, what are some of the changes in the poop that would make someone need to go in and get checked?
So it's not always necessarily the type of change, it's the persistence of it, right? And so if there's something that's new to you that persists. Now, if you go down to Taco Tuesday and you eat a bunch of jalapenos and you know what's going to happen after that, and then you eat that and it goes away, okay, no. But if you get that, hey, that poop, like I feel like I just had jalapenos, but I didn't, and then it never goes away, that's a sign. So you know your body. So if there's a change that happens that persists that you can't explain, you didn't start a new medicine, you didn't change a dose of a medicine, you didn't change your diet or something like that, like those are reasons to have a consultation and let us tell you if you need to be checked. Yeah.
Yeah. Yeah. So the next question says, when you have hysterectomy, can endometriosis still return? So it kind of speaks to the point that we were just making. If you have a not so thorough procedure, your disease process is still there. So a hysterectomy is not a cure for endometriosis. However, I have many patients that want more of a definitive surgery when they're dealing with their endometriosis. They're done having their children, or maybe they're older, or maybe even without that, their pain and their pathology that they've dealt with over the years are so severe, they are done, right? That's many times when some women will choose hysterectomy for any reason that they choose hysterectomy. They really want something that's done. However, endometriosis is growth of tissue similar to the lining of the uterus outside of the uterus. So even if you take the uterus, but you leave all of that tissue growth in other areas in your pelvis, in your upper abdomen, on your appendix, on your bowel, on your colon, on your diaphragm, you will still have pain. No, you cannot put down new disease. The endometrium, which is the lining of the uterus, is gone. So you're not technically able to make new disease. However, that other disease that's there too needs to be resected and removed. So that was kind of that more complex, more thorough, more totally inclusive procedure that Dr. Kingsbone was kind of hinting to earlier. If we leave all of your endometriosis on your bowel, but take your uterus, your symptoms can persist, especially because nowadays we are advocates for women keeping their ovaries unless there's some other really, really good reason to keep it. So you still have the hormone that sensitizes the endometriosis, which will still cause the pain. If you have your hysterectomy and all of your endometriosis removed, theoretically you should be done. You should not be able to make any new endometriosis, but you need that
Yeah.
done by a high volume endometriosis specialist surgeon to make sure it's done correctly.
Yep. 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 Yep.
Question next one. Can fibroids actually cause constipation or painful bowel movements? Absolutely. That's why Dr. King-Mullins has me here. Because we collaborate, friend. We collaborate. If
Yep.
that fibroid is pushing on that colon, it screams. It does. It does tell the story. Sometimes it's back pain. Sometimes it's constipation. Sometimes it's even diarrhea when my patients have endometriosis and they have fibroids. And sometimes it's just that, subtle, like Dr. King Malone says, sometimes it's subtle but persistent. Yeah.
Yep. And I'll cook and one of the things that people because we are talking a lot about, if there's big fibroids or endometriosis in the pelvis kind of blocking things off. And one of the hallmarks of a prolonged obstruction or blockage is actually diarrhea because something is growing and pushing and kind of caving in on your colon. And so now the only thing that can pass by is something that's more liquid. And so we do get um, a volume of patients who will say, "Hey, I'm actually having diarrhea. No, my stools aren't thin," but that's actually the thinnest of the thin, right? Because the only thing that can pass by is liquid. And so any changes that are persistent in the bowels can be a hallmark of either primary colorectal disease or a gynecologic disease. And I actually, again, will um, talk about, and this is not endometriosis related, but just showing how close relatives the GYN tract and the colorectal tract is down there. I just got called in. We'll talk to Dr. Mitzi Davis, a GYN oncologist, at the end of the month. Patient came in bleeding, lower pelvic pain the other day, had been seen by a GYN oncologist and large ovarian cyst, and they thought things were going to be all related to GYN, and there was a colon mass that was identified in someone significantly under the age of 40. And in retrospect, I got called in the operating room, so I couldn't ask questions before, but post procedure asking questions, one of the main complaints was new onset of constipation, and that was how that whole process worked out.
Yeah.
Yeah.
Yeah. Very, very. It's a, important thing, this understanding what's normal and what's not normal, but also that kind of always speculative, like how is my body changing? How is my body aging? Because my husband often reminds me that we get older every day. What again is that realm of normal and not normal. And sometimes you just have to do a gut check every once in a while. That is the reason you have PCPs. That is the reason you have primary, or general gynecologist, just to do that gut check. Like, is this normal? Should my body be changing this way? Is the fact that my bowel movements have shifted and adjusted? Sometimes it is.
Yeah.
But it never feel afraid to acknowledge and bring up the subtle changes that are happening in your body. A lot of times it can save your life. It
Yep.
can. Hmm.
And some of those subtleties happen, and thanks for shouting out the PCPs and the, generalist GYNs, because I have this conversation with patients all the time, even when they're young and healthy and they're listening to what everybody else says and they come in at 45 and get their initial screening colonoscopy. I ask them, hey, do you have a primary care physician? They're like, no, I'm good. And I'm like, you don't know that.
Hmm.
And the best, analogy or story that I can tell on this is if someone's not checking your labs every year, you can be having a steady decline that's normal, 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 normal till it's not. So,
Yeah.
say for example, you show up to the hospital because you saw some blood, some bleeding. You thought maybe it was a hemorrhoid, but hey, let me just go to the urgent care or ER and get checked. They do some blood counts. Your blood counts are normal, right? Okay, your blood counts are 11 and a half. Normal is like 10 and other under, there's a range. But hey, maybe if you were seeing a primary care doctor and every year they've been taking your blood and every year it's been 15, 15, 15, 15, and then boom, 11,
Yeah.
that normal is not so normal anymore, right?
Right.
That is very abnormal for you. So that is the baseline. So if you don't do nothing else, like seeing that primary care doctor or whoever the general physician is, so we can establish a trend for you. So that
Mhm.
way, we know something very early is going on that's different. I mean, again, that can be life-saving.
Yeah. Yeah. What do you say to this question? There seems to be a disconnect between GYN and GI doctors. Do you find this to be true? What are the best ways to find two specialists that connect? Best ways to find your team before surgery?
Yeah. Um, so, however you start your journey with whatever your diagnosis is, and you find, your person, you find your physician, typically, they already have established a team of people that they work with pretty regularly, that they're like-minded, or who they know, like, hey, if I send a patient over there, they're not going to be like, why are they sending this patient? Like, there is a reason to be there. And so while I'm not saying shop around doctors by any means, but again, if there is a team,
I
if you have
am.
a complex medical issue,
I am. Second opinion, third, fourth, fifth,
yes,
if you need it.
yes. But yeah, you need to help establish your team too,
Yeah.
and it's okay. And so I would just, be very vocal, up front with your providers, and be advocates for yourself. Like and you don't always need a referral either. Like I tell people now, in the world where HMOs are not as common as they used to be, like it is okay for you to seek out your own care. And if there's something that you want addressed and you feel like your provider isn't referring you in the right place, please take advantage of, I'm gonna say it, take advantage of Dr. Google to at least empower yourself, but make sure you're looking at reputable sources, okay? But
Not
trying to
TikTok
figure out,
Google, Dr.
hey,
Google.
hey,
No,
okay,
but you
well,
a
I got
doctor
your
on
top
TikTok.
phone.
No, but
Okay,
you a doctor on
okay,
TikTok. There's
okay,
there's a bunch of folks on there that's like,
okay. But yeah,
TikTok, I know everything, and they're
yeah,
not spreading the good
yeah,
news doctor is.
yeah.
Yeah,
But
I 100% agree.
yeah, and any good doctor will not minimize or diminish you seeing another person for either a second opinion or, another subspecialty, whatever. Like, I mean, my interacting with Dr. Hawkins, yeah, I know a little about a lot, but not a lot. And so I'm like, nope, go talk to her. Let her ultrasound you, MRI, you do whatever, review all your stuff,
Yeah.
your labs, and she'll tell you what to do. Yeah.
Yeah. Someone said the response I got from a GYN is that they would just call in general surgery. So when you know better, you do better, right? So if they do not know that you're full of adhesions and the bowel is stuck to the back of the uterus, and that you've had three C-sections and it might be the possibility of adhesive disease, then yes, in that moment the great thing about many hospital systems is that they do have other surgeons at their disposal, like general surgeons or like colorectal surgeons if they're on the floor. So there's nothing necessarily wrong for that. But if they know better, right, if they can fully anticipate based on just listening to your symptoms, really having a thorough discussion with you about what your body is doing and getting the correct imaging. You know, many people I see that said they've seen 5 doctors and nobody ordered an ultrasound when they had pelvic pain or when their cycles started to get heavy and irregular. It's easy. Imaging is some of the easiest ways that we can, diagnostic tools that we can use. And sometimes they really do shed light of what might be, what else might be going on. Sometimes things that we don't know. And then when they're empowered with that information, when you know better, you do better. I'm
Yep.
going to plan. Dr. King ain't gonna be ready at 2 o'clock when a surprise endo shows up on my bowel because she's seeing patients across town. I need to let her know well ahead of time so we can collaborate and coordinate. And I can make you my first case of the day because she can be available at 7 a.m. As simple as that. So when you see specialists, to Dr. King Mullins' point, many specialists have already kind of have their team, have their backup plan, have, you know, that collaborative kind of community of other doctor friends that they will help to take care of their patients. We only want the best for you. So being well prepared and planning ahead of time is optimal. So the plan should not be to just call who's in the hallway. Because sometimes who's in the hallway, I'm like, yeah, no. That no, it ain't it ain't going down like that. Not my
Yep.
patient. So I'd rather
Yeah.
plan. I'd rather
Yeah.
plan.
Yeah. Yeah. Great point. Yep. Cosign.
So what do you think about prevention? And actually, before I ask you this question, what are some of the things that Dr. Tushy Touch Up does? You said tags. Do you
Hmm.
do hemorrhoids? Do you do rectal incontinence? Like if someone feels like every time I pass gas, I pass a little poop. What are the things
Sure.
that you do that you've core for you and have added to your offerings in the last year?
Yeah, so I'm a full service colorectal surgeon, so anything colorectal I do handle and manage. I have over the past several years developed a little bit of a special niche with regard to that whole tissue touch-up area because tissue touch-up itself refers to the comprehensive tailored plan for you based upon your symptoms. Specifically addressing the pelvic floor. So if it's tags, sagging skin, discoloration, scars, you know, if you've had a traumatic childbirth and there's been a tear, episiotomy, bless you, a
Yes,
tear or
that's
an
a good one.
episiotomy, and sometimes those scars don't heal well because it's an emergency, you're bleeding, they just got to sew you up and get you good, and those things can impact you later. Rectoceles, and sometimes they may not be very, very large where you have full on a pelvic floor dysfunction, but that in combination with a thin perineal body or something like that can impact your functionality and your aesthetics and things like that. And so the tushy touch-up procedure itself is basically a comprised constellation of surgical procedures to help you meet your aesthetic, cosmetic, and functional goals. So it may include all of those things. But in my greater role as a colorectal surgeon, I do screening colonoscopies, regular basic hemorrhoidal procedures, major colon resections for colon cancer, inflammatory bowel disease. We also do some nutritional counseling, and we're about to go deeper, deeper, deeper into that because I am talking to a well-trained and experienced dietitian who is going to be providing some consultative, directed nutritional services for guided weight loss management, for assistance with bowels and bowel habit changes that happen with irritable bowel syndrome, Crohn's disease, ulcerative colitis, having an ostomy, pre and post surgery, you're going through chemo, you just want to feel better, like all of those things, because Lord knows we'll get 5 minutes of nutrition changing training maybe in
Right.
medical school. So I'm gonna tell you eat fiber and vegetables, and if that don't work for you, then I'm gonna have to send you to my nutritionist.
Recommendations? Any prevention or supplement recommendations?
Um, so first thing is being as natural as drink as much water as possible. Your body will let you know if you're drinking enough, because if your bowels are super dry and hard, you're not drinking enough water. If your urine is very concentrated, you're not drinking enough water, okay? We don't need to start with labs for that. Secondly, for prevention, high fiber. So, eating the colors of the rainbow, minimizing processed foods. When you shop at the grocery store, shop at the periphery of the grocery store, not going up and down the aisles. That's where you're gonna find the most natural and unadulterated products. But besides that, our number one preventive measure is doing exactly what we're doing right here,
Yeah.
talking,
Yeah.
having a conversation with your family and your loved ones, and knowing what's going on with them and their bodies so you can know what your risk factors are and how quickly you need to be running to the doctor to start your colonoscopy screenings or whatever else that you need to do for your health and wellness. Yeah.
Yeah. So this one is a great question. So how do I know if my pain is coming from fibroids, endometriosis, or my colon? Since we done told the people they all mixed up right
Right.
there together.
You see a specialist. No, but I mean, but a lot of this, again, the whole the whole issue is that these symptoms are very non-specific.
Yeah.
And so seeing a trained specialist who knows how to tease out certain bits of information, um, you know, is your pain traditionally just associated with ovulation or with your cycle? Or is it persistent? Certain things that we can kind of tease out to help direct you, but again, like she said, imaging, ultrasound, ain't nothing to do with it, but just to put that little ultrasound on you. There's no radiation, there's nothing crazy to it, just to get a baseline understanding of what's going on, and that'll help us figure out, which rabbit hole we need to go down. Yeah.
Yeah. Can endometriosis be seen on pelvic MRI? Not always, and most of the times, no. So most of the endometriosis that we find when we do surgery, which is how we do the definitive diagnostic type of, that's the procedure, so we can actually put our eyes on it. We do laparoscopy with a camera. Most of it is literally the size of like gunpowder. That's traditionally how it's described. So that you can't see on imaging. But sometimes there are nodules, or sometimes there's cysts in the ovaries called endometriomas. Those are very obvious and easy to see on imaging. And sometimes when the colon is involved, especially because I send my patients to imaging specialists that have radiologists that know what I'm looking for and know how to read my imaging to see best as they can if there's a possibility of endometriosis, especially involving the colon. Sometimes they'll say that the colon is tethered to the back of the uterus, or tethered to the cervix, or tethered to the bowel. And sometimes it shows nothing, but because the patients have symptoms and I send them to my colorectal friends, they may do a colonoscopy, and that colonoscopy tells the story. So it's not always seen on imaging. Unfortunately, we're still working on kind of refining that. But I actually think it's much better than it was when I trained 14 years ago. 14 years ago, we weren't getting some of the detail that we can get with imaging now.
Yeah.
Do you actually order your MRI different when you're looking for specific things for the
So
colon?
yeah, so for me, rectal contrast plays a huge role in what we do. And when someone's having pelvic pain or things like pelvic floor dysfunction, um, it's called a dynamic MRI or an MRI defecography. And so they put a little contrast gel in the rectum. And most times I know people are just like, oh my God, that sounds so disgusting. But we're not static individuals, right? We move, we shake. Some of the symptoms people have are increased with bowel movements or urination or intercourse or something like that. And so by doing it that way, they put the little contrast in the rectum, and then they have you do a few different activities: cough, push, squeeze, bear down. So they're seeing what the bladder is doing, what the pelvic floor muscles are doing, what the rectum's doing, what the uterus is doing. So it kind of we get the snapshot in time, but we also get the dynamic changes. And so we understand, yeah, this is why you can't hold your poop, because this is happening, or this is why you're having incontinence of urine, because something's pressing on it, or it's bulging down when you try to push. So that's the type of MRI that I'll frequently order.
Awesome. Sonia is she killing it with the questions today. So she asks, she said, I've heard this combo amongst women, so I wanted to ask here, do you ladies feel women are being overdiagnosed or misdiagnosed with IBS when it might actually be something gynecological? Sometimes. Sometimes, okay, so this is this is a thing that I'm huge on. It is possible to have more than one thing going on at a time, right?
Yep.
I don't know if you guys all remember there was a Instagram, since we're on Instagram, is fitting, an Instagram influencer that passed away from cervical cancer last year. She also had huge fibroids, and it was said that her diagnosis was missed in both the fibroids and the cervical cancer, or it may have been that they were kind of focused on the fibroids and missed the cervical cancer. It is possible to have more than one thing going on at a time. It highlights right back to the things that we've been talking about during this wonderful discussion. It's been great.
Yep.
It's paying attention to your body, those subtleties, having a conversation with your doctor when something is changing. And yes, they may say, and maybe, you getting a little older, or it may have been your diet, or it may have been these things that are happening. And it's okay sometimes if you feel like, actually, maybe they didn't hear me, or maybe, we need to dig a little bit deeper because I really feel like something is not right. You can get those second and third opinions if necessary. But yes, sometimes you can have IBS and endometriosis, and sometimes you will be diagnosed with IBS because, it's a more commonly known
Yep.
syndrome, especially if you are seeing a GI about it, because all of your
Yep.
signs, your symptoms point to a GI thing going on, and it could be endometriosis, right? And sometimes
Yep.
it's subtlety of your symptoms or even your history, because if they dig back deeper and further, you were telling them in middle school and in high school, I was missing class every time my cycle came on. I was nauseous, vomiting, and had diarrhea. I had that rectal kind of spasm that is very typical of endometriosis. And over time, my mom took me to the doctors, and then they sent me to the GI, and then they said I had IBS. And sometimes they go back a little bit, then it's like, oh, actually, no, you may actually have endometriosis. And it's, a part of the story that may have been missed.
Yep. Yep. And the hallmark that I tell patients, when they're like, oh, I have IBS or this or that, I ask them what sort of evaluations and workup, have they had. Um, because the literal name is irritable bowel syndrome. Syndrome is a constellation of symptoms, and so the it's a diagnosis of exclusion. That is how we in the colorectal world refer to it. So we need to exclude other treatable causes for those symptoms before we diagnose you with irritable bowel syndrome, because all we have to treat IBS with is symptomatic treatment. So we have to rule out Crohn's disease, ulcerative colitis, or any other gynecologic disorders or food allergies or sensitivities and all of those things. So once we've ruled out something that can be, more formally treated, then we start with the medications and the dietary changes and things like that, specifically geared toward IBS. And so part of that workup and evaluation sometimes will require referral to an an endocrinologist or a gynecologic surgeon or a gynecologic specialist or urogynecologist to complete that workup and evaluation, to make sure we have that right diagnosis.
Awesome. Yeah.
Yeah. Well, listen, this has been an amazing conversation. The best way to kick off the Love Below series. We want you all to feel empowered to have conversations about intimacy, colorectal health, pelvic health, how it impacts you. You should not be living a life where you're worried about how and where you're going to use the restroom, either urine or bowel function, engaging in intimacy if it's time to continue or start your family or just feel more confident about yourself. So we're starting with Dr. Hawkins, our fibroid and endometriosis specialist. We're going to be talking to menopause specialists, gynecologists, that focus on pelvic health, pelvic floor rehab therapists, GI, all of those things. So stay tuned for the continuation of the series of The Love Below. I'm Dr. King-Mullins, also known as Dr. Tushy Touch Up, and I'm going to leave the parting words for Dr. Hawkins.
No, I'm excited actually for the whole series. I will be tuning in every step of the way. I love the dynamic speakers and guests that you're going to be having on. And I'm really looking forward to this journey with you. I'm excited.
Awesome. Sounds good. Y'all make sure y'all follow us and keep sending in those questions. We'll be monitoring the chats and the comments. And so if something pops up later, we'll make sure we get back to you.
Awesome.
All
Thank you. Thank you
right.
for having me.
You're welcome. Bye for now.